PC Manoria to please, so let me first, introduce Dr. Manoria, and then maybe he can present his talk. And by the time of lunch, I think Dr. Vijan also would have reached his destination and would be able to present it live rather than video. So all right. So Dr. Professor P.C. Manoria is an MD and DM and a number of other degrees where he doesn't find an appropriate space, so it's written, etc. So it means he is a very, very laureate person. He's director of a Manoria Heart and Critical Care Hospital in Bhopal, and he's an honorary physician to His Excellency in Madhya Pradesh, and the past national president of 9 national associations, which includes Cardiology Society of India, Association of Physicians of India, ICC, and past dean of ICP, and so the past chairman of Hypertension Council of Asia Pacific Society of Cardiology, is a past president of SARC Cardiology Society. He is awarded 7 lifetime achievement awards, and the most prestigious out of that, I would say, is Bharat Ratna Award given by our ex-president of India. His special awards in cardiology, and he has been organizing number of national and international conferences for last about half a decade, and he is executive president of World Congress of Cardiometabolic Medicine. He's edited a number of books and published a number of into index journals, and still counting. The number of lectures is more than 800, and he's still counting. So I invite Dr. Manoria, please, to start sharing his screen first, and then. Yes, sir. We can see the screen and we can see you, and all good to go, sir.
So at the outset, I'd like to thank Dr. Singh, and it's indeed my great pleasure to participate in this webinar on echo. The topic which I'm going to talk is guideline-based assessment of diastolic function. Diastolic function is a very complex topic, but I'll try to present a very simplistic view so that our junior colleagues can grasp it better. The last couple of years had witnessed spectacular advances in the field of diastology, both in terms of enhanced understanding and in the availability of newer parameters to assess diastolic function. These are the conventional methods which we have been using for several years: the transmitral Doppler, the annular TDI, the left atrial volume index, and the TR velocity jet. But now the British Society of Echocardiography has also incorporated left atrial strain in evaluation of diastolic function. And I'm sure Dr. J.C. Mohan is there, who has wide experience in left atrial strain, and after the talk, certainly you'd like to have his expert comments. The left atrial strain has also been incorporated in the algorithm for assessing diastolic function. And then GLS, although, as we heard, is an index of systolic dysfunction, it picks up subclinical systolic dysfunction, but on occasion it gives diagnostic pictures, particularly amyloidosis, as cherry on top. So this may be utilized in certain diseases where we have a diastolic dysfunction, but TLS may give a diagnostic spot diagnosis picture. And left atrial strain, as I'll discuss, has been incorporated in the algorithm for assessing diastolic function. Now, whenever we ask our student, what is the systolic function of this patient? The answer is immediate: ejection fraction less than 35, so GLS available, they'll say GLS. But the same question when we ask our resident, what is the diastolic function of this patient? There is usually silence. The reason being, echo assessment requires multi-parametric approach for evaluation of relaxation, chamber compliance, and filling pressures. And very important to remember, no single parameter best defines diastolic dysfunction. The other thing you have to realize is that invasive methods of measuring left ventricular relaxation and filling pressures are considered the gold standard for investigating diastolic dysfunction. However, the high temporal resolution of TTE with widely validated and reproducible measures available right at the bedside without the need for invasive procedure have established echo as the primary imaging modality. And echo does not directly measure the pressures in the left ventricle, very important to remember, but the flow patterns are extrapolated to predict pressures. So normal diastolic function implies adequate filling of the heart without excessive increase in diastolic pressure at rest and even after exercise. As shown is there is always an overlap between systolic and diastolic function, so that patients of diastolic dysfunction may also have systolic dysfunction, and GLS may be abnormal in substantial number of patients. Patients of systolic dysfunction not uncommonly have diastolic dysfunction, and in patients of systolic dysfunction who are decompensated, diastolic function is invariably present. So ejection fraction is a continuum. There cannot be very strict compartment. Overlap is always there in assessment of ventricular function and heart failure. Now, this has been the conventional way of reporting diastolic function. We've been reporting like this for several years. Grade 1, abnormal relaxation. Grade 2, pseudonormal. Grade 3, restrictive, reversible. And grade 4, irreversible. But now the British Society of Echocardiography has tried to give new reporting recommendation so that even a non-cardiologist can understand what is the diastolic function of this patient, because abnormal relaxation, pseudonormal, many of the non-cardiologists may not accept. So this is the recommendation which is given for reporting diastolic function. You can report normal diastolic function or normal diastolic function for age, particularly in elderly where there's abnormal relaxation. The second way to report is impaired diastolic function with normal LV filling pressure at rest. So the individual understands he has diastolic dysfunction, but the filling pressure no. And the third is impaired LV diastolic function with elevated LV filling pressure at rest. And if you have features of heart failure, when you examine these patients after treatment, the diastolic function may be equivocal, and there are no left-sided disease to suggest heart failure. You can suggest a diagnosis of HFpEF, and if need be, an exercise echo can be done to demystify the diastolic dysfunction, which may be equivocal at rest. Now, these are the routine parameters which we have been using for several years. The E by E prime more than 14, septal E velocity less than 7, lateral E velocity is less than 10 centimeters, TR velocity J at 2.8 meters per second, and LV volume index more than 34 ml per square. But now LA strain has to be utilized because it's very important in assessment of diastolic dysfunction. For measuring E to E prime, we have to calculate the E velocity on the mitral Doppler and the E mitral annular velocity on the tissue Doppler, the medial and the lateral. This is how we measure the transmitral velocity by the pulse Doppler. And this has already been covered, Dr. Vijan. We have an E wave, we have an A wave, we have deceleration of the E wave and the EA ratio. This used to be called as impaired relaxation. You can see the A wave is increased and the E is smaller, the EA ratio is reversed. The isovolume relaxation time increases, the deceleration time increases. And this is pseudonormal, which appears like a normal, but you can easily confirm it and differentiate it from the normal associated left atrial enlargement, left ventricular hypertrophy, large atrial reversal wave in the pulmonary venous flow, or you can change the loading condition, say by Valsalva. Here you can see this is a pseudonormal pattern which is reversed after Valsalva to abnormal relaxation. And then we have the restricted pattern, which is the old terminology. You can have the E becomes taller than A, maybe more than 2. This slope becomes steep and A becomes smaller, and this may be reversible or irreversible. And here you can see restricted pattern. This is again the transmitral, and this is the tissue Doppler. And this shows an overview as to what happens in the transmitral inflow. This is normal, we have said. Then when relaxation, A becomes taller. Then again, E becomes taller. And this is A. And finally, very tall E and small a. Now, tissue Doppler is mandatory for evaluating diastolic dysfunction, and we assess tissue Doppler at the medial mitral annulus, which is the normal TDI E prime is less than 7, less than the septal, which is more, less than 10. And this is again an overview as to what happens to the annular velocity. Normally, E is greater than A, then A becomes greater than A, and then finally both become smaller. And E by E prime less than 8 is normal, 8 to 14 is indeterminate, and more than 14 is elevated. These are the limitations. You can have mitral valve problems or abnormal conductions or CRT, and which can interfere with the diastolic function. This is an overview. I think time will not permit. Then we have the left atrial volume index, which should be measured in the apical 4-chamber and apical 2-chamber view at left ventricular and diastolic and systolic, the largest LA size at the frame just before the mitral valve opening, using the Simpson biplane method, and the index to BSA and left atrial volume index more than 34 ml per square meter is considered abnormal for diastolic dysfunction. The LA volume should be measured to be in the focused LA view, which is usually little medial and posterior to the apical 4-chamber and 2-chamber views, because long axis LV and the long axis LA are not in the same line, and they usually are at an obtuse angle. And if you are measuring LAVI by 2B, it has some limitation that there may be LA foreshortening, geometric assumption may not be valid, and manual tracing has its own problem. So 3-dimensional measurement is preferred but may not be available always. This is the TR velocity. Jet more than 2.8 meters per second is the cutoff point. So this has been the conventional way of assessing diastolic dysfunction. So we utilize all these 4 parameters. 0 to 1 positive is normal. 3 or 4 positive is diastolic dysfunction. And if they are 2 positive, it is indeterminate. So now we have this algorithm from the British Society of Echocardiography, which further refines the evaluation of diastolic dysfunction. And in subset of patients where this indeterminate or equivocal, we can make it more precise. So looking at these 3 parameters, the E by E prime, the LA volume index, and TR velocity, if 2 or 3 criteria are negative, obviously, this is you assess relaxation by the age-specific E prime. Normal E prime means normal diastolic dysfunction. If 2 or 3 are positive, obviously, immediately, this is diastolic dysfunction with elevation of LV filling pressure. But on occasions, we have only 2 criteria are available, 1 positive and 1 negative, and then left atrial strain will come into picture. You have to assess the pump strain more than 14%, of the reservoir strain more than 30%. And if it is like that, more than that, again, assess relaxation by the age-specific E prime, and again, you can categorize like this. But if the pump function more than 14 or reservoir strain more than 30 is not there, then you have to look at the left atrial strain less than 18%. If yes, again, it goes into diastolic dysfunction with elevation of LV filling pressure. But if it is not, then you have to assess the other parameters like the atrial reversal A wave duration more than 30 milliseconds or the L wave more than 20 centimeters per. So this is certainly helpful in patients where the diastolic function are equivocal on the conventional parameter. I think pulmonary venous Doppler is important. We have a systolic wave, which is greater than the diastolic wave. And we have diastolic dysfunction, this reverses, and we have a large atrial reversal wave. And this shows that this is normal. As the diastolic dysfunction progresses, you can see the diastolic wave is getting bigger and bigger, and atrial reversal is there. So what are the supplementary measures we adopt? In one of the measures we adopted mitral valve A and pulmonary vein atrial reversal duration. Now, normally this is the A wave of the transmitral and this is of the pulmonary vein. Normally the difference in the mitral A and the pulmonary vein reversal duration is less than 30. If it is more than 30, it indicates increased LV filling pressure. We also look at the L wave. L wave occurs due to transmitral flow with a velocity of 20 meters during diastole. Normally during diastole, no flow due to increase in the left atrial pressure, which occurs due to continued PV flow into dilated and incompliant left atrium, resulting in increase in the left atrial pressure. Then we have the mitral annular TDE by A ratio. Normal is greater than 1, it becomes less than 1. Certainly it indicates diastolic dysfunction. IVRT also is an important component. How we measure, I think most of us are familiar with the gap between the closing of the aortic valve and the opening of the mitral valve. And it also varies with age. The figures are there on the slide. And it has an inverted U-shaped relation. So normally, as abnormal relaxation proceeds, it gets longer, then returns to normal, and then finally again shortens. The other parameters we measure is IVRT oblique E minus E. So normally the time between the peak R wave on ECG to the onset of both E and A waves. If there is diastolic dysfunction, this delays the onset of E prime and prepones the onset of E. So the time difference between the onset of E and P prime wave therefore increases as diastolic function worsens. IVRT is included to incorporate left atrial pressure. So if IVRT TE minus E can be useful in borderline or significant mitral valve disease also. If the ratio is less than 2, it suggests has a high sensitivity and specificity for elevation of left atrial and diastolic pressure by 15 millimeters or more than that. Now, normal mitral A velocity wave transit time to the outflow tract is also used to assess left ventricular diastolic dysfunction, and a peak-to-peak transit time less than 45 milliseconds or onset-to-onset transit time less than 50 is suggestive of diastolic dysfunction. And you can also assess the deceleration slope of the pulmonary veins, and shorter deceleration slope of the pulmonary vein Doppler suggestive of elevated LAP. If it is less than 175 meters per second, milliseconds, 100% sensitive, 94% specific. Deceleration time of more than 275 milliseconds has sensitivity 88%, a specificity of 95% for LA, being less than 6 millimeters per mercury in patients with normal sign aneurysm and normal ejection fraction. Mitral inflow propagation velocity is not often used because it is less reproducible. You may not have always a straight line. The slope may also be curvilinear, so less reproducible. But VP more than 50 centimeters per second is considered normal, and EYBP more than 1.4 predicts. But I don't think this is being commonly used. This is, if you have atrial fibrillation, there are problems in assessing diastolic dysfunction. This is again an algorithm provided by the British Cardiac Society. So if you have atrial fibrillation, you look at these parameters: septal E by E prime more than 11, mitral E velocity more than 100, E deceleration time less than 160, and TR velocity more than 2 point. Now, greater than 3 criteria are negative, normal filling pressure. If more than 3 criteria positive, impaired diastolic function with elevation of filling pressure. But there's insufficient step 1 criteria for decision. Then you look at these 3 again. Left atrial strain comes into picture. So LA reservoir strain less than 16, body mass index is related to atrial fibrillation, obese patient more atrial fibrillation, pulmonary venous S by D ratio less than 1. So greater than 2-step criteria is negative. More than 2-step criteria, again, diastolic dysfunction, elevation of LV filling pressure, insufficient is indeterminate filling pressure. Now, on occasions, we have to evaluate patients of, say, HFpEF who have been treated, and when they come to us, their diastolic function at rest is normal. So stress echocardiography has to be done. You can say this is mitral inflow, abnormal relaxation has been transformed to restrictive pattern, and same is there for the mitral inverse. This is going to be demystified by Dr. Parashar, but this has to be done if your diagnosis is HFpEF, and at the time of examination, the diastolic function is equivocal. This does not exclude the diagnosis of HFpEF. So why we are so much interested in diastolic function? Diastolic dysfunction is the underlying pathophysiological mechanism for HFpEF, which accounts for 50% of patient heart failure in West. India is reported to be 30%, but more because there may be problems in diagnosis. The severity of diastolic dysfunction is an important predictor of adverse cardiovascular event prognosis and assessment helps in guiding treatment. We have a lot of new treatments for HFpEF. It is useful in preoperative fitness of patient with LV systolic dysfunction. Suppose a patient comes for a non-cardiac surgery, he has left ventricular systolic function. If his diastolic function shows a restrictive pattern, we will not permit him surgery. The treatment, if it shows abnormal relaxation, he can be permitted. So even with the same ejection fraction, somebody has a restricted filling, so he will not be permitted for surgery. It is useful in distinguish between cardiac and non-cardiac cause of dyspnea when this is a problem, and also helps in deciding the urgency of implantation of LV cardiac. Suppose you have a irreversible diastolic dysfunction, or by other parameters, these patients should be offered these modality of treatment at the earliest. So thank you very much for your kind attention.
Thank you, sir. That was a wonderful presentation, both the content, the expression, and the graphics. Graphics were superb.